Good afternoon, everyone, and welcome. I want to introduce Dr. Deepak Mohan. He's the medical director at San Joaquin General Hospital with over 2 decades of experience in laboratory medicine and hospital-based diagnostics. As the medical director of a clinical laboratory in San Joaquin General Hospital in California, he has led transformation initiatives to improve efficiency, compliance, and diagnostic accuracy. Dr. Mohan has played a key role into the integration of Abbott's GLP automation system into his hospital core lab, driving innovation through streamlined workflows and data-driven quality improvements. A strong advocate for practical and sustainable lab modernization, Dr. Mohan brings grounded and result-focused perspective to an evolving field of laboratory automation. A few disclaimers. Support for this program is provided by Abbott. The speakers are presenting at the request of Abbott. The views and opinions expressed in this presentation are those of the speaker. Any results, findings, or conclusions are reflected of the speaker's experience and should not be considered a product claim. Individual results may vary, and this presentation is not intended to represent or guarantee any laboratory will achieve the same or similar results. So thank you, Dr. Mohan. Will you give us a little feel about the patient population you serve and the laboratory that you have?
Well, first of all, let me thank everyone for the opportunity to speak today, and thanks for listening as well. You might be wondering why I am up here. I have a small hospital lab. It's a 198-bed hospital in the middle of pretty much nowhere, California. We are close to Stockton, and we are also off the 5 freeway, which is a very busy freeway. But we also happen to be 70 miles from the nearest trauma center. So we're a designated level 2 trauma. And we're also a safety net hospital. Many of you all probably work in hospitals larger than mine. So automation, why does this man come up here and talk about automation? Shouldn't that be somebody from Quest or LabCorp or one of the large entities? Well, this technology is meant for the smaller labs. It's meant for every lab. I don't think we could do the things that we do in our hospital today without the help of a great partner like Abbott. And I say that from the bottom of my heart. I take my job very seriously because I took an oath to patients. And I want to provide the highest level of care to the patient population we serve, which is a safety net hospital. So things like the opt-out program for hepatitis and HIV, using the highest level 4th generation testing means a lot. And for us, when we have to choose the right partner, we don't get too many second chances. It's just one chance. We got to get it right. We got to choose the right partner, and we have to deal with that partner for however length of the contract, 5 to 7 years, as you all know. We don't have the luxury like a university can go, yeah, I'll get this one for that, a third party for this, and a third party for that. They can't do. We can just go with one vendor that can offer everything in one package, and Abbott truly was that for us.
So where do you think holds back the clinical lab today?
There's a lot of factors. One of the biggest problems we were facing with the previous generation and other situation is, where is the tube? It's the biggest question that comes up. So we used to spin our troponins offline. And you had to because the previous track system treated every sample as the same. So in our current situation with GLP, there's a prioritization. So if it's a troponin or if it's a pro-BNP or one of the stat tests, it automatically goes to a stat setting. And it's all automated. We don't have to do the offline spin. And at any given moment, we know exactly where the specimen's at. We don't have to think about it and say, well, we have to locate that specimen, or the ED doesn't have to call us and say, where is that specimen? We sent it to you. It's already been 2 hours. I need that troponin result. This patient's having an MI. If you know anything about, the previous speaker spoke about MI and cardiac syndrome. If you're that late with it, not only you're in compliance risk, you're also at a risk of losing a patient's life. I took an oath to those patients. So every one of those samples is near and dear to my heart. You don't want to have any workflow bottlenecks. And Manual errors have all kinds of issues. You know, you forget something there, somebody forgets to do that. We're human beings, but the automation gets it right every time. So it's not just about the speed of something, it's about the certainty.
Fantastic. So as we talk about you moving over to GLP, you had a legacy Abbott track, legacy equipment. Talk to me a little bit about your vision about the samples just kind of running themselves.
Well, recently I had the luxury, this is prior to some of the things that happened, but I got a Tesla, and I don't want to get into the whole thing, but I love the FSD feature on the Tesla. And the reason I love it, and I'll tell you why, and I'm talking about something else, but there's an analogy here. When I'm driving with that FSD on, it does 90% of the driving. But the 10%, the most important part, I take over. If I see some construction or I see something going on where I have to take, that's what the track is all about. Our CLS, our scientists, who are the most important part of the lab, get to do the 10% that's most important. That's the power of GLP. That is the power. It's not, oh, it's going to do everything and replace our. No. You still need to be in the driver's seat. You still need somebody in the driver's seat, but that person can do so much more. And they're concentrating on the most important 10%. You know who it benefits? It's my patient. I took an oath to those patients. They're number one in my heart as far as what we do. But there are other things that are amazing about the track. You know, you have unified automation, and for us, it's a total solution. Things that we don't normally think about. I don't know if any of you have the inventory manager. Inventory manager is a game changer, but they tried to sell it to us, but it was something we could never buy. It was part of the package. We got it. Now I can see savings, and we'll talk about those savings, but it doesn't sell well to go to your CEO and say, I'm going to be able to save you on reagent costs, wastage, and all that. They don't believe it, but when you have it, you actually start to see it. So how our, for instance, the inventory manager works is, as it comes through the loading dock, 95% of inventory is brought in. As soon as they take it out of the fridge, all of those are taken out of inventory. So we know exactly how much inventory. There are more days of like, oh my God, we ran out of calibrator for this. I have to get it from another lab. We haven't had that in 6 months. Continuous real-time QC monitoring. Why should we wait a whole day to know the QC is out? Throughout the day, we'll know. If any moment our QC goes out, we know real time. That's very important. Preventative maintenance. We have people from Abbott coming out, and they'll come out and say, hey, this particular thing needs to be replaced, even before it goes out. It's magic. It just happens. These are things that you didn't know that you needed until you had it. And you know, there are so many more features I can talk about. These are the ones that come to mind. But our staff are much happier. And I'll tell you one anecdote before I get to the next slide. And this is something that you all have to hear. We had the previous generation track, which was essentially the 3600 Impeco line, which was the previous generation. And one of the staff came to me, and they were, you know, lab assistant. They were not high in the pecking order, but he rarely came to me. He came to me, doctor, can I talk to you? I said, what is it? He said, thank you. I said, why? What did I do? He goes, you brought this new track online. I used to come home every day with a headache, literal headache. That headache has gone away. It was because of the noise. The previous track was at least 30 decibel points higher. You know what that can do to a person's health? And our employees are the most important thing. They're the ones who are delivering the results to our patients. And you're doing that to them. I thought that was the one testimony that probably, I mean, I didn't know, if I knew ahead of time, I would have done it faster. But we did it, we were one of the first customers in California, so I don't know how much faster. But I know that we did that for him.
I love it. So talking about your decision to transform, so for everyone to understand, we had the architects, the legacy Impeco track, we had instrument manager as our middleware, and Bio-Rad as the QC. And Dr. Mohan said, I'm going to GLP, Alinity, AMS, which is the next generation middleware. I'm going to add this inventory manager thing. Oh, by the way, I want to go to Alinity. And I want to go live in one day. So talk to me about your decision to really transform surgically.
Well, I got to first thank them. You know, my mind is always forward. I'm always looking what's the next thing. I take Wayne Gretzky's quote to heart. You don't skate where the puck is. Because today, the old track, accelerator, that's where the puck is. GLP, what you see right there, actually, that's the best slide of the day is right behind you. That is the future. That's where you want to be. That's where you all should be in 5 years. If I was the CEO of the country or the president of the country, I would, make sure that every lab in the country has this, because it's not just good for your employees, it's going to be good for all the patients in this country to be able to get as many as those out there. And I say that with a lot of passion because I see how many lives it's transformed. In our ED, we're picking up cases of HIV. We have a homeless population. Do you know how many people a homeless person potentially could spread HIV to if they don't know the diagnosis, are not treated? Any guesses? Many of them are in, let's say, I won't talk about these things because they're not socially acceptable, but they may be in a profession where they can't spread it. If you prevent one of those things, you're talking about hundreds of people not getting HIV. That's a game changer. We have a 4th generation HIV test on an automated system. That should be the kind of peace of mind that we're looking for with an automated system. That we are being able to provide the highest level precision, speed, as well as ease of use. Well, ease of use.
So if you had to give me 3 reasons to do this transformation, what would it look like?
Well, I got 3 reasons there. You can read those. But I'll give you one of the reasons, because of what we normally do, is we'll ask our lab scientists first. We kind of do it in a reverse. We had a choice of 3 vendors we went through. And on the cost basis, the administration wanted something. And I don't want to say what name of that company is, but it's not fair to them. They're not here to defend themselves. But I'll tell you this. I went to my staff, and they work in other places as well. And they knew the alinity. And this rarely happens. Usually it's like a 10-2 split. This was 12 people saying, we want the alinity. And you know the things that they said? Well, doctor, we want it because we can hot swap the reagents. I don't know if that makes a big difference to you all. It's a huge thing. The maintenance doesn't take that much time. The other aspect that they mentioned is the way that the reagents, you load them in, a lot easier to use. I can't put that on a slide, but their lives are better. And then that one person that came to me and didn't even know that it's going to change his life, where he doesn't have the headache, literal headache. No, I mean, we get our headaches, but he literally had a health problem because of the track, with the decibel level. Another funny anecdote, because of that, one of the staff came to me and said, because we do MTPs, which is with a trauma center, these are massive transfusion protocol. So they overhead page those. One of the staff came to me and said, did they turn up the volume on that? No, they hadn't. Because the decibel level has become so low on the GLP, they felt that it's become so loud because it was quiet in the lab. Finally, they can hear each other talk. They can communicate. You know how much of a game changer that is?
So what was the reality check coming out for you since you've been doing this?
Yeah, I've been a pathologist for 20 years, and I'll be very honest about this. It was my first job, so I had a lot of pressure on me because I didn't know what the standard was. I needed to be the best, and I was always afraid of any sort of failure. So I went above and beyond what most medical directors ever did. And if there was a problem with the ED, they would and I made myself accessible. So they'd call me on weekends and something went wrong or a specimen was lost or what was happening. And I would have to deal with those phone calls. And I took all those calls. I was the only pathologist that was full-time. There was a lot of stress and burnout that was going on that I didn't even realize. You know, I'm the person that call. In 6 months, I think I got 1 call or 2 calls. It wasn't for Abbott. It was for a micro problem. So I'm not going to trivialize what we do. Some of the things that we do are behind the scenes. Most of the things we do don't get recognized, but you don't want them to call you. You don't, because that's when something goes wrong. Our job is make sure that they never call us.
I love it. So let's talk about the finances. You've been live for a little over 6 months. What does your ROI look like?
I think it's been fantastic because, I mean, always when I look at ROI, I'm not a bean counter, I'm a doctor. I made a note to the patients. First, number one is turnaround time. Why? The ED is the nerve center of the lab is the nerve center of the hospital, and the ED tells you what's going to happen to your hospital, whether it's going to win or lose. Because if you can't control that ED population, the time that a patient comes to the ED, the time that they're discharged or they're admitted to the hospital, you've lost. Your hospital's lost. And the lab is that nerve center that can control that. It's the only place that it happens, where 70 to 80% of the lab information is where the diagnosis of that patient is going to take place. And if we're slow, the hospital is slow. So the ED turnaround time is our turnaround time. So if we improve by 30%, ED flow changes. So you're not going to get the feedback from anybody else other than the ED providers. I got that feedback. They said, "Doctor, you're doing something different." I said, "Yeah, we have. We've changed our technology." Because they didn't understand all the things that we have to do manually when we had the previous track system. We had to spin offline, we have to do this, because there was no priority. Everything was routine. Now we have the system deciding what's priority, what's routine, we can batch. It knows everything, and we have a storage module, and it can pull things out of the storage module. You put an ad on, it'll bring that out. All the stuff that we had to do. Oh, is the sample good? Well, we have an HIL indicator. We have a volume indicator. It knows everything. It knows. We're on autopilot. We're never going back. We're not going to go back to the manual system. In fact, we don't have downtime, so we don't know how the whole system is. I'm scared in another 6 months, if something does happen, people are not going to know how to do the manual stuff anymore. We have a downtime procedure. You have to actually go back and read it, I think.
I love that. So talk to me a little bit now that it's been in action. What does the dance look like?
Well, as I said, we're partners. And when you're partners with somebody, you have to know how to dance. And so sometimes it's a give and sometimes it's a take. And would I say there were no problems? I would be lying if I had to say that. There were some hiccups here and there, some missteps. But those things were smoothed over because we found out quickly, they responded quickly, things were back to normal. And for instance, well, I'll give you one of the examples of the misstep. This happened. I mean, you can see the system right behind you. The cars, they work pretty well. Sometimes they do fail. Well, you're going to say, oh, they fail. Okay. Well, when the track failed, the whole track would go down. With that system, one of those cars, they're all independent. One of those cars fail, you have dynamic rerouting. It'll take the sample and, like if you had a traffic situation and you got caught in traffic, you're like, why can't you create a new road? That system has another parallel road. It'll start traveling on a different road if a certain road is blocked. It'll alert you, the tech comes out, takes off that car, you're back running. You're back on full automation now. But you don't have delays, right? You don't have the delays that, oh, you have the track down. Now I have to reset the track. You have to do this. Because we did have to do all of that before. So that's why it's a choreography. You know, it's just a dance. And I just love watching that. I mean, to me, it's mesmerizing just watching it. And the best part, it doesn't give you a headache at the end of the day.
So I wanted to just show a quick video of your lab. I think one of the things that was very interesting as we were doing this transformation is we wanted to put the track in the existing space that the old track was in. And we ended up saving space for you. So can you talk a little bit about what you did with the saved space?
Absolutely. So our goal from the beginning, because before chemistry was automated, our goal was to go core lab automation. So in the same footprint, and again, each lab is different. And again, I'm talking about a 200-bed hospital. Your lab might be different and different shape. The advantage of DLP is it's highly customizable. You can look at it. They have these spirals they can do. They can do all kinds of shapes and sizes based on what it's tailor-made to you and your lab. And what we wanted to do is connect coag. So we have a third-party coag that's considered best in class, so we went with them. And then another third-party for hematology was also considered best in class. And we're adding another vision product to be able to have that added to it. Now we're cooking with gas. Total automation. Remember, call back to where I was telling you about our designated level 2 trauma. Now, if we have a trauma that takes place at 2 a.m., I have very limited staff at 2 a.m. I have lab assistants who can't sign, obviously they can't sign the release cases out. It has to be scientists. But what happens at that 2 a.m. call? What happens? Well, the 2 a.m. call causes everyone to float over to the blood bank, right? Everyone's over in the blood bank because an MTP requires that extra staff because we're small. We need to do things, more things with less people at that time. Well, with our system in place, the vision is, it's not completely done yet. The connectors have not been available, but the vision is to be able to release hematology, release coag from the blood bank. Because the ED is still open, right? At 2 a.m., the ED is still open. Just because we got a trauma doesn't mean the ED closes. They're still busy. And they're probably busier now than they were before. So we're able to, and as I said, we're the nerve center. If we shut down our lab, then everybody else is affected. The entire hospital is affected. So we're able to provide that service. Now, this has not happened yet, but in my mind, I can see our scientists flowing from chemistry, flowing from hematology, over helping with the trauma, packing those coolers, because we have to. We're a little bit different than most labs. We're not in the same building. We're separated, so we have to actually pack a cooler and send the blood. So those coolers have to be packed, and platelets have to be readied. And, FFP has to be thawed. Everything has to happen. So they need physical people to do that. We haven't gone to robots yet to be able to do that. But this gives us the ability to flex, the ability to do everything that we're doing with the same level of staff, and probably even do more. Our area is growing. The population is growing. People have more need for these kind of safety net services. So how do you do all of that with the same staff? Because staffing is the hardest part. We all know that. You all know that staffing is the hardest part. So it's not necessarily, well, this is going to fire a bunch of people. No, it's not going to happen. You're going to have the same number of people, but you're going to be able to do all the things that we need to do because as the population ages, all our services are going to be needed more and more. Our volumes are just going through the roof. But can we hire the staff to keep up? No way. There's just no way. There's not enough scientists out there. And MLTs can definitely fill the gap. We use some of our MLTs for certain things, and they can definitely work on automation. They help very good on that, and our LAs, but they can't do everything. You still need the scientists for the 10%.
Fantastic. So leading very well into partnership, it's turned into a little bit of a buzzword. You and I have known each other for a little over a decade. What does the Abbott partnership mean to you?
Yeah, and that's the partner over a decade, and she means personally as well. It's a consistency. It's not being good some of the time. It's being good all of the time. That's consistency. I knew Ida when she was with the information systems, and the relationship we formed over that decade is there's a certain level of trust. I knew if I reported a problem, it'll get solved. That at least I'll have an answer to what my question was. And that partnership grew. And they don't have a lot of turnover. A lot of places, I've noticed, a lot of other vendors, you see a new face every 2 or 3 months. They come in and say, oh, I'm so-and-so, I'm new. With Abbott, it's pretty much the same people, and that consistency matters because they get to know us. It's a partnership. It's a dance. It's a choreography. And having the right partners is not just technology, even though, if you look at that I went all around here. I'm telling you, that is the best track anywhere. So you're getting world-class technology, world-class people, world-class service, although they hardly show up because you don't need them to, but they do come in and do the preventive maintenance. They're behind the scenes. They come in and actually, have you ever had a vendor say, what's your slow time? When is your lowest volume of samples? We'll come in and do the PM during that. That's Abbott. So if you tell them, hey, our slow time is, let's say 11 to 1 p.m., and that's when we have more staff. Okay, they'll come then. Because it's preventative, right? It's not a breakdown, they come in and have to fix something. That is the choreography. That's the dance that you want to be in.
I want to give a quick story, if you can go back one slide.
Go back one slide.
So this sign is above their GLP in their main lab. And so the first track we had the innovation laboratory, and everyone's like, we're going to do a new sign, yes. And I said, absolutely, we're going to do a new sign. Everyone's going to sign it. And so one of your most senior employees asked me, can I kiss it? And I was like, absolutely, you can kiss it. And so she puts on her red lipstick and she says, I wanted to see the last track, and I'm going to put my DNA on here. And so her DNA is hanging above the new track before she retires. And I just thought that was awesome.
Ida, thank you for bringing that up. I don't want to say her name because I didn't get a disclosure from her. She is what we call, I guess, what do they call that generation? I think I'm Gen X. I'm not sure exactly the name, but the generation of the 70s. I don't know how they define it. But you have different generations working in our laboratory. Millennials, they love this technology. The usual staff that don't like it is that generation, okay? She tells me there are a couple of technologies I love. One is the iPad, because I get to see my grandchildren on the iPad, and she knows how to use that technology. And this technology, because it just works. Because people don't like technology for the sake of technology. They want something that works every time. They want it to be easy. They don't want to fiddle around with stuff. This just works. You can't try to go and ask one of these ladies to, try to put something on the Alinity C, try to load reagents. Try to load it on the wrong one. You can't. It just works because it's shaped in a certain way. People thought about this. It's made for the people. Most times the engineers make it. This is made for you. It's made for scientists. So the technology is not meant to be something that replaces us. This technology is meant to be a part of us so that we are the technology and the technology is us.
I love it. And so leading into your people, you have a very unique setup where you do have Gen Z, who notoriously doesn't like to come to work, all the way through, boomers. So talk to me how you've been able to keep them motivated when you can't necessarily pay the San Francisco salary, and they're still wanting to work not only with the Gen Z, but how do I get the millennials to stay motivated? How do I get the Gen X to help and train? And how do I keep my most senior seasoned staff on board as I kind of groom the next generation? How has Abbott helped you with that?
Well, I'll do a call back to what I said about the gentleman that came in and told me about the headache. Well, that gentleman stayed for 7 years and dealt with it. Millennials, not so much. When they get the headache, they'll say, well, I need to find a place that doesn't give me a headache. That's what they do. They walk out the door. So to maintain them, you have to have something exciting. The technology is exciting. They love that technology. And you have to give them a good environment to be in. If you don't provide that, they're out the door. They can find another job. They're getting paid $15, $20 more in another place. Our county hospital. We do have a good pension program and all that, but they're 20-somethings. They don't think about pension. That's maybe if it exists 30 or 40 years down the road, maybe. I mean, I'm the generation probably thinks more about that sort of thing, but for them, it's about the here and now, and to have that technology available in your laboratory is what keeps them in the door, not out the door. So it is a somewhat, when you think about it, is it about the machines? No, it's more about the people, the support. It's the tools. If you give the people the right tools, they're going to love doing their job. And that's what you want to do. Salary, yeah, it works for a while, but it's not the end-all and be-all. It's from what I've seen, is the happy workers give the best results for our patient. And I always thought of our patients as number one. And I knew employees are important. I used to have them as number two. But now I've kind of changed up my order. I took an oath to my patients. So they're always going to be 1A, but my employees are 1B. The administrators are, no, I'm just kidding. All right.
Love it. So thank you so much, Dr. Mohan. We had a couple of questions that came in previously, but if you guys want some Q&A, Dr. Mohan will be sitting. The main question was, what was the transformation of changing middleware look like for you?
Oh, that's a great question. That's one of those things I didn't even know that we needed it. We had another third party before with a previous track, And that was something that was a little different for us because when we went, because we had to use AMS, and so for us it wasn't really a choice. We just got it along with the track. But then you had all these hidden benefits we found out about later on because we also use the Abbott QC. I forget the name. I think you probably can help me with the name of the Abbott.
He had BioRed before, moved over to Technopath.
Yeah. So we had the BioRed Unity before, and it was great. It's a good product. And so with that product, the issue is we had to enter a lot of things manually. But with the Abbott product, it's, again, back to the scientist. It makes their job a lot easier because everything's barcoded. We just load it on the track, and QC is done in the morning. It flies by. And we used to have resistance because, like, there used to be a war of shifts because night shift is the slowest shift. And, we used to have them do the QC. And then in the morning shift, they'd be like, oh, no, we have AM rounds. We don't want to do it. Now it's a reverse war. They're like, we'll do the QC because they know that's the easiest part of the day. And you kind of, you're given a little bit of extra time if you do the QC. So actually QC has now become, it used to be the bane of their existence. Now it's something they want to do.
Love it. Thank you so much, Dr. Mohan.
Sure.